Very good afternoon to all the participants, and thank you all for joining. We have this session that we have organized is basically in response to a consultation paper that we had uploaded on the NHA website, where we had drafted the vision of the NHA for moving towards value-based care. So I'll request our Deputy CEO, sir, Dr. Bipul Agarwal, to please give his opening remarks and set the stage for us to make the presentation. Over to you, sir.
Yeah, thank you very much, Dr. Pinja. Thank you, Dr. Sudha, for organizing this. And on behalf of NHA and the HPQA division, I welcome and thank all the participating states and the senior officials present over this call. As we all are aware that, and Dr. Pinja just mentioned that we have floated a document to seek comments and feedback from the stakeholders on the value-based care approach. Now, in over the last 3.5 years of implementation of this scheme, we have come a long way, starting from a scheme with a limited expanse. We have been joined by now 33 participating states and union territories. So barring a few states, all are now participating, and almost 50% of the population of the country is getting covered through this scheme. Most important aspect of this scheme is to provide quality care to the beneficiaries, and in terms of our efforts to ensure that, we have in fact devised multiple mechanisms, starting with the incentivization of quality. And since we didn't have any other parameter to go for quality, we adopted the quality standards adopted by NABH as the sole criteria for the certification, and plus few questions on PMJAY as the criteria for selection and giving incentives under the scheme, apart from other incentive criteria, but quality was limited to that. So what has happened as a result is that not only that the uptake of the scheme in terms of 7% utilization by the hospitals empaneled have so far been given quality accreditation. In fact, we started the giving incentives to the Brown certified hospital also. That also has not yielded fruit, but even if it had yielded, I don't think that that is the ultimate objective. So the ultimate objective is on the outcome. So just on the basis of certification, even if a hospital is certified, it does not show that the patient is being treated well. It is just that the hospital conforms to few quality standards which are expected. But what is the kind of quality of treatment being imparted, whether the hospital is following the norms set out and the objectives under the scheme by giving patient the care and the support, not resorting to any fraudulent practices, and also the outcome based, so the patient is not getting readmitted because of the same disease not getting cured completely, or there are any mortality. So all these parameters probably we have not been able to incorporate, and that was the basis for thinking about it. And good, and we were lucky enough to get Dr. Prinja and Dr. Sudha on board last year, early this year. So in fact, we have now started thinking on broader terms of how to ensure quality and how the quality should be defined under PMJAY. And in an effort towards the direction, we studied the quality parameters across the globe, and what we have come across is that there's a concept of quality-based care, the value-based care approach, that basically focuses on the outcome. And how do we measure the outcome? How do we measure the patient feedback and conforming to the standards, plus what bare basic minimum services are expected in the scheme? We, as a first step towards it, have devised the concept of value-based incentives, and ultimate objective is to reach towards the value-based care. And in that, the support and feedback and comments and guidance from the stakeholders present over this call is the most important, because you are the people who are going to implement it. It is you who have to be in touch with the providers on the ground, and you are the ultimate gainers to say, even for the political setup. Unless the beneficiary is satisfied, the scheme would never be able to achieve the intended objectives that we have defined for it. So my request is, I am sure that most of the states and especially the people who are dealing with quality and the hospital networking must have gone through the consultation paper. Even those who have not done that, please go through it. Please see as to what is the vision of NHA in that, and whether our vision is myopic, whether we need to do something more, we need to incorporate more parameters, or we feel that few of the parameters listed are not workable on the ground. So please do give us your feedback, because this consultation is extremely important for us to take this program to the next level. And this is something that is the vision of future. So what we decide now would be implemented over the next 5 to 10 years. So for the country and a scheme of this magnitude, which is the biggest scheme in the world of this nature, we most important stakeholders have to work together and ensure that the quality that we intend for our beneficiaries is up to international standards, and that quality has to be measured in a way that is objective, that is clearly measurable, that is easy to monitor and also to implement on the ground. It should not become a very complicated criteria measure value based care. With this, I would like to hand it over to Dr. Pinjay and Dr. Sudha to take it forward with a request to all stakeholders. So please participate, please give us the maximum suggestions you can, so that this exercise is most fruitful and we tend to gain out of your experience and knowledge and implementation of the scheme. Thank you very much, Dr. Pinjay. Over to you.
Thank you very much, sir. So, as sir has mentioned, we have posted this consultation paper, and what I'm going to do now is that I have a presentation that I'll run through over the next half an hour, and then we will open it up for questions and comments. But what we'll request is that as much as possible, please give us feedback and comments on the issues that you feel are important for us to address as we go on to revise this particular strategy. And I'll request that you can keep posting your queries in the Q&A box or the chat box that is available as an icon down below on your taskbar, because that will enable us to collate as many as possible questions that are available. But other than that, we have a link that is also available on the PMJAY website, and I'll show you that link towards the end of my talk. So we'll request you to send us formal suggestions or suggestions for improving or maybe modifying this entire approach. So basically, the consultation paper is divided into two sections. The section 1 talks about the value-based care in general, and it talks about the different concepts, the need, and the different facets of value-based care that we are trying to incorporate within the PMJAY ecosystem. And what we have tried to articulate is that we have to make this decision of moving from a more traditional way of paying the providers, which in most countries varies from either in most countries ultimately relies on the quantity of services being delivered, whether it is a fee for service based method of payment in certain countries, or the way that we pay in our setting, which is a case based bundled payment. But even a case-based bundled payment in a way is delivered to a provider based on the number of, let's say, surgeries that are being performed or the number of patients that are booked for providing medical care. So in a way, eventually it is the amount of money that a provider receives is contingent upon the number of patients that are seen or the quantity of services that are delivered. However, what is a more appropriate way is to also look at not just the quantity of services being delivered, but also make a sense of what's the outcome of those of the patients who are being treated, what's the quality of services that are being delivered, and then what it means is that whatever incentivization is being determined, it is determined based on the health outcomes that are that the scheme is able to generate for the intended beneficiary, who is the patient of who's covered under the scheme. And there is no denying the fact that we need to definitely keep a focus on quality. And that's because there has been a very strong evidence that came in 2018 through the Lancet Commission's work, which showed that the proportion of mortality that is amenable to healthcare, that means the proportion of deaths that could have been avoided if the healthcare was available. And it was shown that of those people who died who died prematurely, 60% was due to poor quality care, whereas 40% was due to lack of access. And that reflects on the fact that in our entire attempt towards universal health coverage, there's been quite a significant focus on improving access. But what the recommendation is that there has to be a very strong concerted effort that has to go for improving the quality of care as well. And in line of that recommendation, there have been a number of different initiatives that have been undertaken within the PMJAY ecosystem to improve the quality of care. starting from establishing quality cells at the state health agencies, which are entrusted with the task of nudging the hospitals, the empaneled hospitals, to have better quality processes, better infrastructure, and better outcomes of the treatments. And there is now recently a quality audit checklist has also been developed, on which the quality cells have been trained to perform some supportive supervision and try and help the hospitals to improve quality. Other than that, we have developed a method of quality certification under the PMJAY, which includes bronze, silver, and gold certificates, which are done in partnership with the QCI, and we follow the NABH standards for the silver and the gold. And recently, we've also introduced the NQAS certification for the public hospitals. There are also other non-financial nudges to improve the quality. For example, on giving some recognition to hospitals that perform better in terms of these quality standards on certain national days like Republic Day or Independence Day, or keeping a focus on the quality during the celebration of different international days. The AB PMJAY NABH Center of Excellence is another new standards that have been developed through the NABH for specifically looking at the super specialty care. So these are some initiatives that have been introduced that are currently in place. And as I mentioned that having accreditation leads you to gaining more in terms of the financial incentives also. So with bronze, silver, and gold certification of the hospital, the hospitals are entitled to 5, 10, and 15% additional incentive over and above the price that has been set. And the NABH bronze certification is available not just to the hospitals that are empaneled under the scheme, but even non-empaneled hospitals can also apply for a PMJAY certification. The entry and the final accreditation for the NABH is managed by the NABH, and they have a incentive of 10 and 15%. The NQAS certified public hospitals are also entitled to a 15% additional incentive over and above the price that is set. So what does this value-based care ultimately, what are the different connotations of value-based care? The different aspects of the value-based care include that it focuses on improving the quality of care. It focuses on trying to generate better health outcomes. It works with the providers to nudge them to help the patients to improve their health. It aims at also trying to standardize the different processes that are involved in delivery of healthcare. So having well-laid SOPs, well-laid standards of how to deliver healthcare services, etc. And ultimately, as payers or the SHAs, it is also important to make sure that we get the best return of the investment that we are making. So which means that we try and have better healthcare efficiencies. And this entire value-based care has different value propositions for, if we look at it from a different lens. So if you look at it from a personal lens, which means the patient's lens, the connotation of value in value-based care is much more driven by the individual patient values, which means having the best satisfaction for the care that is being provided. In terms of the technical connotation, it involves that there is a higher outcome that you have been able to achieve in terms of the health gains with the amount of resources that you have been able to spend. So with the available resources that have been spent, you're able to maximize the amount of health that you have been able to gain at the population level. But the value proposition is not just in terms of technical efficiency, it is also in terms of allocative efficiency. That means you're also able to ensure that there is more equitable distribution of resources, and there is an equitable utilization of care across different population subgroups, across different regions, districts, the more hard to reach areas versus the more easy or the central cities, etc. And finally, at the societal level, the value-based care ultimately offers an opportunity for a healthy population that is able to not just contribute to being healthy, but also is able to contribute back to the society through social participation.
Dr. Shankar, there's a request to have a mix of language. So if you can also Hindi, a little bit on the Hindi also.
Sure, I'll do that. Thanks. Thanks for pointing out. I wasn't able to see the chat box. Thanks. So what I was trying to say here that अगर हम अलग-अलग लेंस से देखें तो there are value based care का मतलब अलग-अलग ऑडियंस के लिए अलग-अलग तरह से हो सकता है, and each individual, whether it is an individual या हम SHA की लेंस से देखें या हम हॉस्पिटल के लेंस से देखें, हर किसी स्टेक होल्डर के लिए वैल्यू बेस्ड केयर में वैल्यू का मतलब इट कुड बी स्लाइटली डिफरेंट. And this slide eventually tries to expand on the previous slide जो हमने पहले दिखाई थी, to show कि जो different elements of value based care हमने एक पिछली स्लाइड में दिखाए थे, उसमें which all are the things that are currently being introduced or are being in currently in practice, या फ्यूचर में हम किन चीजों को करने का प्लान कर रहे हैं. तो मैं इसको क्लॉकवाइज चलूंगा एंड आई ट्राई टू एक्सप्लेन ईच वन ऑफ दीज. So for example, पहली चीज हमने लिखी हुई है integration of care delivery system. So what this means is कि there should, so the different interventions that we are doing on this particular aspect is, number one, हम कोशिश कर रहे हैं कि as much as possible there should be an continuum of care. Continuum of care का मतलब क्या है कि हम प्राइमरी, सेकेंडरी और टर्शरी केयर की लिंकेजेस को एस्टैब्लिश करें such that जब पेशेंट डिस्चार्ज हो तब वो वापस जब अपने होम सेटिंग में जाता है तो प्राइमरी केयर टीम उसको सर्विसेज प्रोवाइड कर सके, एंड जब वो पेशेंट प्राइमरी केयर स्टेज में डिटेक्ट होता है, शुरू में उसकी अर्ली डिटेक्शन होती है, देन वी आर एबल टू रेफर दैट पेशेंट अप, एंड देयर इज सम काइंड ऑफ इंफॉर्मेशन सिस्टम चैनल, इंफॉर्मेशन चैनल्स आर आल्सो इंटीग्रेटेड. सो इस एस्पेक्ट के ऊपर वी आर ऑलरेडी वर्किंग. There are some initiatives that have already been done, but there is more work to be done in future that is in pipeline. अभी जो हमने रिसेंटली हेल्थ बेनिफिट पैकेज 2022 में रिवाइज करके अनाउंस किया है इन अप्रैल, इन दैट हेल्थ बेनिफिट पैकेज हमने एडिशनल 2 टाइप ऑफ पैकेजेस इंट्रोड्यूस करे हैं, अगेन ट्राइंग टू हैव दिस काइंड ऑफ इंटीग्रेशन इन केयर डिलीवरी. One type of package is the follow-up package, which means that the people who are undergoing complex surgeries, let's say in cardiology या CTVS या urology में, they have to be taken care of after the surgery also, so that the outcomes of the surgery are good. ऐसा ना हो कि उनका दोबारा से कॉम्प्लिकेशन हो जाए जिसकी वजह से रीएडमिशन करना पड़े, फिर से सर्जरी करनी पड़े और उसमें उतना ही खर्चा और हो जाए. So as a result, the follow-up packages have been introduced so that subsequent follow-up with appropriate diagnostics and appropriate medication is also provided to the patient. Similarly, हमने day care packages introduce करे in certain specialties like mental health, for example, which does not necessarily require a hospitalized treatment, but it requires a very elaborate psychotherapy or a psychoanalysis of the patient, जो कि day care setting में होता है. इसके अलावा जैसा कि मैंने पहले बताया था, we have introduced, we have set up these, the SHAs have set up these quality cells, जो कि hospitals के साथ मिलकर काम करेंगे in order to improve the quality. We are also trying to work on expanding the geographic reach of providers. That means हम अपनी empanelment जो है उसको भी assess करते हैं कि हम किस तरह से जिन areas में hospitals नहीं है वहां पर additional hospitals को identify करें. बट ओवर एंड अबव हम ये भी देखते हैं कि जो हॉस्पिटल्स डिफरेंट एरियाज में लोकेटेड हैं उनकी जो पेमेंट सिस्टम्स हैं, दे शुड आल्सो ट्राई टू बी रिफ्लेक्टिव ऑफ द कॉस्ट स्ट्रक्चर्स. अगर कॉस्ट डिफरेंट होती है एक पर्टिकुलर एरिया में सर्विस प्रोवाइड करने की, तो प्रोवाइडर को अकॉर्डिंगली उतना रीइंबर्समेंट मिलना चाहिए. सो एज अ रिजल्ट रिसेंट जो हेल्थ बेनिफिट पैकेज हमने अनाउंस किया था उसमें डिफरेंशियल एचपीपी प्राइसिंग इंट्रोड्यूस करी है, which means hospitals that are located in tier 1, tier 2 or tier 3 cities, they are paid differently. Secondly, we do recognize कि जो hard to reach areas होते हैं वहां पे automatically because of the distance, because of the vulnerability of the area, cost of care is a little higher there. Plus we want to also incentivize setting up of more hospitals in such areas. So as a result, there is an incentive over and above the differential price, especially for the aspirational districts, which is 10% over and above milta hai. There is a lot of work that we all know. The entire system of PMJAY is run by a TMS that works on the principle of having a complete paperless transaction. Plus the ABDM is trying to link the entire ecosystem of all healthcare providers, healthcare suppliers, and the healthcare beneficiaries. And this is something that is still a work in progress, but once it is completely in place, it is going to completely transform the system. हम एक और कॉन्सेप्ट के ऊपर काफी काम करने की कोशिश कर रहे हैं, एंड दैट इज जो कि हमारा इस वेबिनार का भी सब्जेक्ट है कि वैल्यू बेस्ड इंसेंटिव। तो उसमें हम अपने जो पेमेंट सिस्टम है उनको वी वांट टू लिंक दैट टू द टाइप ऑफ टू द परफॉर्मेंस ऑफ द प्रोवाइडर। और इसमें हमारे दो इनिशिएटिव्स हैं। एक हम ऑलरेडी पायलट स्टार्ट कर चुके हैं 5 स्टेट्स में, विच इज फॉर डीआरजी। डीआरजी इज नथिंग बट डायग्नोस्टिक रिलेटेड ग्रुप्स, जिसमें कि हम अपने पेमेंट सिस्टम को इवॉल्व करने की कोशिश कर रहे हैं इन अ वे दैट अ प्रोवाइडर फॉर अ गिवन डिजीज ऑल्सो his payment is linked to the level of complication or the level of severity of the patient that he is treating, rather than एक single uniform price उसको मिले। तो इसके लिए हम एडिशनल डेटा कलेक्शन 5 स्टेट्स में ऑलरेडी इनिशिएट कर रहे हैं, और उसके रिजल्ट्स के बेसिस पे वी विल कम अप विद अ प्लान ऑफ हाउ वी कैन पोटेंशियली इंट्रोड्यूस दिस न्यू रिफॉर्म ऑफ पेमेंट। बट वी आर ऑल्सो प्लानिंग इन टर्म्स ऑफ वैल्यू बेस्ड इंसेंटिव्स, जो कि मैं लेटर पार्ट ऑफ द प्रेजेंटेशन में आपको दिखाऊंगा। हमने एक और मेजर एक्टिविटी अंडरटेक करी है, विच इज एस्टैब्लिशमेंट ऑफ अ हेल्थ फाइनेंसिंग एंड टेक्नोलॉजी असेसमेंट यूनिट विद इन द एनएचए। और इस यूनिट का फंक्शन क्या है? इस यूनिट का फंक्शन ये है कि ये एक सिस्टमैटिक मेजरमेंट कॉस्ट्स और आउटकम्स की करे फॉर ऑल टाइप ऑफ हेल्थ केयर इंटरवेंशंस, सो दैट हम ये असेस कर सकें कि जो भी नई इंटरवेंशन, नो ड्रग या डिवाइस या टेक्नोलॉजी हम इंट्रोड्यूस करना चाहते हैं अपने हेल्थ बेनिफिट पैकेज में, दैट शुड बी कॉस्ट इफेक्टिव, because we understand that it is important for us to make sure that the money that we are spending is spent on interventions that are cost effective, that help us get the maximum return of the money that is being spent. हम कॉल सेंटर के थ्रू भी यूजर एक्सपीरियंस को असेस करने की एक सिस्टमैटिक अटेम्प्ट करते रहते हैं, which is an ongoing effort, but we are trying to strengthen this as part of the value based incentives more. And ultimately we are also trying to organize the care to focus much more on the conditions, and इसके अंदर हम comprehensive primary health care के साथ linkage कर रहे हैं। हमारी जो prices हैं, they are bundled in a way that we are not looking at individual services but the entire package of care as such. So this slide basically tries to show कि हम what are the different things that we are trying to do as part of overall approach of value based care. So this was our first chapter in the paper, and इस चैप्टर में हमने अल्टीमेटली जो क्वेश्चंस दैट वी हैव पोज्ड टू फॉर कमेंट्स एंड ओपिनियन आर दीज 3 मेजर क्वेश्चंस, जिसमें कि हम आपको ये इनवाइट कर रहे हैं, इफ यू कैन गिव अस सजेशंस ऑन whether all the aspects that we are covering in order to capture the value, are these sufficient or not? क्या कोई ऐसे एस्पेक्ट्स हैं वैल्यू बेस्ड केयर के जो कि ओवरऑल फ्रेमवर्क में ऐड होने चाहिए, and to comment on the overall appropriateness of value-based incentives to the healthcare providers. So those are 3 questions on which we have sought the comments and the feedback. The second section of the paper is specifically focusing on the value-based incentives. और इसमें हमने जो explain किया है इस पूरे chapter के अंदर, वो ये explain किया है कि what are those indicators that we can adopt, that we can select for computing these incentives, and how can we measure them, and then how can we analyze them. तो ये 3 aspects के ऊपर हमने इसके ऊपर discussion करी है इस particular chapter में, and I'll now try to show you what we have proposed. So currently the model that we have for incentivizing the providers, there are various types of incentives that currently exist, whether it is based on accreditation, or it is based on location of a given hospital, or it is based on whether it is a teaching or a non-teaching, and there are different levels of incentives. Although 2 type of incentives, which are metro city and teaching hospital, ये अब in the new differential pricing system जो हमने introduce किया, this will get subsumed within this only. So this will no longer remain when you have HPP 2022. But broadly speaking, if you look at this, जितने incentive structures हैं, they are all primarily related to accreditation based systems, जो कि मोस्टली इनपुट्स और इंफ्रास्ट्रक्चर को असेस करते हैं। तो मूविंग फॉरवर्ड, द वे दैट वी आर ट्राइंग टू रिवाइज द इंसेंटिव स्ट्रक्चर, और द वे दैट वी आर प्रपोजिंग टू रिवाइज द इंसेंटिव स्ट्रक्चर इज दैट व्हाइल वी कंटिन्यू टू यूज द सर्टिफिकेशन बेस्ड इंसेंटिव, बट उसकी जो वेटेज है वो सिर्फ 50% ही होनी चाहिए, और जो रिमेनिंग 50% वेटेज होनी चाहिए इन द ओवरऑल कंप्यूटेशन ऑफ इंसेंटिव, दैट शुड बी बेस्ड ऑन कि आउटकम्स ऑफ द ट्रीटमेंट कैसे हैं। So most important is that we need to now define कि how do we measure the outcomes of the treatment so as to determine this remaining 50% of the incentive. तो what it means is that we need to identify indicators जिसके basis पर हम ये outcome को determine करें. तो हमने ये 3 अपने criteria set किए कि how do we choose these indicators, and this is in line with what our Deputy CEO sir was also mentioning in his opening remarks, that the choice of these indicators are to be such that number one, ये overall principles of universal health coverage के साथ there should be some similarity with that, या overall जो principles of health system की जो performance measurement होती है उसके साथ alignment रहे. नंबर 2 ये है कि that ये यूजुअली जो routinely available data होता है उससे ये generate हो सके ये indicators, rather than को बहुत extra effort नहीं इसके ऊपर लगे, because otherwise the entire system will be driven to simply collect and invest a lot of time on collection of this data. And the last part is that this data, whatever we collect, should be valid, and it should not be, it is not possible कि जो providers हैं वो data की जो या तो entry में गलती कर दें या वो गलत data ही provide करें अपनी तरफ से so that उनके indicators ज़्यादा better लगें. So there should not be any possibility of any kind of gaming, and the indicators should really reflect on the outcome of the treatment. So based on that, हमने ये देखा that if we look at the universal health coverage, then there are 3 broad objectives of universal health coverage. एक, better health outcomes होनी चाहिए. Secondly, there should be financial risk protection. That means लोगों का बहुत खर्चा नहीं होना चाहिए. And the third is that the care should be responsive to the needs of the patients, which means high quality, respecting the dignity of the patient, etc. तो हमने इन तीनों domains के लिए then we tried identifying indicators. So the indicators that we have are number 1, beneficiary satisfaction. Number 2, there should be no confirmed grievance. These are 2 related to the responsive care. Any out-of-pocket expenditure that has been charged to the patient for medical care for the package that has been utilized, that is again something that is going to be monitored and measured. And to measure the health outcomes, हमने 2 indicators choose किए हैं. Number 1, that whether or not there is any readmission within 1 month for the same condition that for which the patient was treated. That is number 1 indicator. And number 2nd indicator is ki what is the improvement in the overall quality of life of the patient. So this is the most fundamental outcome that we want to see, that ultimately it benefits the patient in terms of its health outcome, and we will try to measure it in terms of the overall improvement in quality of life. Now I'll try to describe each of these indicators. So these are the final set of 5 indicators that we have proposed: beneficiary satisfaction, extent of out-of-pocket expenditure, improvement in health-related quality of life, hospital readmission rate, and a confirmed grievance. There were some other indicators also that were considered during our deliberations and discussions. And ये 3 indicators और थे जिनके ऊपर काफी discussion हुआ. For example, looking at hospital acquired infections, these are also important indicators of quality. Second, लेकिन the problem with this indicator is that this is subject to the reporting by the hospital. और hospital reporting में हमें लगा कि काफी bias हो सकता है, तो इसलिए हमने इसको drop किया. Number 2, there was a lot of discussion on mortality to be used as an indicator. So while we capture mortality in our TMS also, but the problem was कि अगर हम mortality को as an indicator use कर लेंगे to incentivize the hospitals, then there will be an automatic incentive on the hospitals to actually treat those patients that are less severe and who are not likely to die, for example. And that may mean that there might be care that is denied to those who are more sicker, etc. So we have specifically, while we continue to measure mortality, we will not include that as a measure to pay incentive to the hospital. The third indicator, which is considered as an important indicator for value-based care, is that there should be an appropriate length of stay. It should not be too long. And इसके लिए हमने भी काफी discussion, deliberation किया. But again, we realized that if we keep length of stay also as an indicator, then it may push the hospitals to maybe even discharge patients who may require a slightly prolonged duration of hospitalization. And as a result, it may create some perverse incentives, which we did not want. So as a result, these 3 indicators, while they are important, they could be potentially considered. We have not included them at this stage. And एक overarching eligibility criteria है for any hospital to avail any incentive, and that is that there should be no confirmed fraud against the hospital. Now I'll come to how we collect this data and how we score this each of this indicator so that we compute the final incentive amount. So the first indicator is beneficiary satisfaction. It is already being collected as part of the call center interview that happens on the second day after discharge. So second day after discharge call center से already call जारी है, उसका system already in place है. तो we will use the same, just that हम उस question को थोड़ा improve करेंगे और उसको एक kind of a visual analog scale पे we'll ask the respondents to rate how much they are satisfied, and then we will try to compute percentages that how much what was the average level of satisfaction of patients who were treated in a particular hospital. So according to that, marking system has been created. We have created this marking system in a way because we recognize that in majority of the beneficiary satisfaction surveys that are created, generally patients tend to report higher levels of satisfaction rates. So it is very few proportion of patients who report that there is a low satisfaction. So इसका जो हमने cutoffs रखे हैं वो automatically हमने थोड़े higher रखे हुए हैं for people to be eligible for different levels of marks. Second indicator जो हमने choose किया, that is readmission rate. Again, this is auto computed through the TMS data because there is a way to track a particular beneficiary from the ID, and within 1 month, if the readmission is taking place for the same disease condition, then we will consider it as a readmission. Certain packages जहाँ पर ये readmission is not should not be considered, like dialysis or chemotherapy या कुछ और day care packages, उनको इस measurement से exclude कर दिया जाएगा. We will not include these packages in the overall measurement strategy. And again, इनकी scoring criteria के लिए we have kept certain cutoffs, and these cutoffs are considering certain standard international benchmarks of what should be the permissible levels of or acceptable levels of readmission that could be possible. So considering that हमने ये compute किए हैं. Third हमने indicator जो as I said was out of pocket expenditure. Again, this is being asked currently also in the call center interview that takes place on the second day of the discharge. And here our policy is strict that if there is any out of pocket expenditure that is reported by the patient for something that was related to either medicine, consumable, or any direct medical expenditure, so then there will be no marks that would be given. Now there was discussion on this particular indicator also because we generally say that any out of pocket expenditure, so there should be a punitive action on the hospital itself if it is reported. Now the point is that in usual practice in hospitals, whenever there is a reporting of the out of pocket expenditure, there is a grievance and there is an examination of that, and if found true, then the hospital is asked to return back the amount to the patient. That's the general principle that is followed. Or if it is repeated, then there is some advisory and some action that is taken against the hospital. What it means is that generally in most situations, the action is related to the specific case where the out-of-pocket expenditure is being reported. However, in this case, the incentive will be applicable based on any out-of-pocket expenditure, even in a single case, for all the other care episodes that are also utilized in a given hospital. So what it means is that we are kind of enlarging the scope of the punitive action that is taken to the hospital in terms of this financial incentive that goes beyond just a particular single case, but to other cases also it will get affected in a way because he doesn't get the incentive for any of the case then. If there is a confirmed grievance against the case, again there is 0 marks for that particular thing. Again, this data will be fetched from the CGRMS portal. So what it means is till the first, second, and third, and fourth, these indicators are already in place in the current system. There are mechanisms to collect this piece of information also. The only piece of information that will require additional data collection is the measurement of health-related quality of life. This is something that is a very standard process that is followed in a lot of other developed countries, and what we propose is that we will use a very simple instrument, which is the EQ5D tool, which only asks 5 questions to the patient in terms of the level of mobility, self-care, usual activities, pain, discomfort, and anxiety. So these are just the 5 domains, and there are these just 5 questions, and the patient simply reports in terms of whether he has no problem, some problem, moderate problem, severe problem, or a very severe problem wherein, for example, he's unable to walk or unable to wash or dress himself, for example. Now, what the data would have to be collected only just based on this. So you just have to say that what is the level at for each of these 5 domains, based on which profile of the health state would be determined, and automatically there would be a computation of the utility score that is available through a value set that has already been generated for Indian population. So this will auto calculate the quality of life, and it will apply a score to a given patient. And this measurement will take place at two time points. One, at the time of the admission by the PMAM, and second, at the time of the call center interview that takes place on the 15th day of the discharge. So what it means is that this is the only indicator where there is an additional data that will be collected, and that too at the PMAM level at the time of admission and at the time of call center interview that takes place on the 15th day of the discharge, which is again a call that goes routinely, but just that we are adding this additional question. And based on the difference of the scores for quality of life that will be reported by the patient, the assessment would be done for the hospital performance. And here we are proposing a percentile based method of improvement. So that means the hospitals will be ranked relative to each other in terms of the extent to which the quality of life improves for patients who are treated in the hospitals. So these are not absolute benchmarks. These are going to be, in a way, relative benchmarks. So this is just to summarize the same thing which we have addressed, that how the assessment of the EQ5D 5L tool would be administered. At the PMAM administers is at the time of admission. There is a profiling that will take place. There would be automatic IT integration of the value set, which will compute a score for the quality of life of the patient. Then at the time of the 15th day following discharge, a follow-up call through the call center will be administered, which will again follow the same principle of health profile would be assessed, and then automatically through the IT enabled value set configuration, the quality of life would be determined. And these two sets of measurements would help us to assess the improvement in the quality of life. What we are also proposing to do is that we are proposing to create an app that would be available with the patient as well. And it is not just the system that we are creating for this kind of data collection, but the patient whosoever is literate and they have the app, they have this opportunity to provide their information by themselves also. So for a lot of each of these things, like expenditure or the quality of life or the satisfaction after the treatment, etc., we will create this kind of a simple set of 5 questions tool that the patient can also themselves fill up. So which means that we are in a way trying to empower the patient or the beneficiary to himself or herself report back on the outcomes or the experiences. And the way forward that we are proposing is that we would like to undertake a pilot based on this approach in 5 to 6 states. And then this would involve training the PMAMs and the call center employees also to undertake the kind of the additional data collection on the quality of life, etc. There would be some IT integration for generating auto generating these outcome based indicators. And then we will try to study the data that gets collected over a period of a quarter of a year, and then based on that, perhaps rework and refine the strategy for ultimately providing the incentives. We also hope that besides just creating a demand for this value-based incentive by placing this app in the hands of the patients, we also want to create a dashboard on the website to provide a picture of the hospital performance on these indicators, which would be available, which would be there for public consumption as well, where the beneficiaries can also see the performance of different hospitals in terms of each of these different 5 domains, whether it is user satisfaction, patient satisfaction, or there is any, or the outcomes of the treatment also in terms of improvement in quality of life, etc. And once available, then this can kind of be used by the patients to even make decisions. So it's like whenever there is you have to travel and you have to go to visit a particular city, and you try and look at that which are the good hotels in the area, and you try and look at certain sites that provide you some kind of such star rating of the hospital. So this is now the rating of the hospitals in terms of some of these outcome-based indicators that are reflective of the value. So this is all that we have proposed in the consultation paper. In terms of the second chapter, we have invited feedback and comments from the stakeholders in terms of the appropriateness of each of these 5 indicators that we have proposed, and any suggestions, whether there are feedback on more indicators that should be considered, or some problems in the current set of proposed indicators. We've also invited comments on the methodology that we have proposed for collecting the data for each of these indicators, and also the proposed computation methodology and the marking system that we have proposed for each of these 5 indicators. And then we've also asked that if there is a additional suggestion for more indicators to be incorporated that perhaps represent the value in the overall connotation of value-based care, then we may be provided those suggestions in terms of what should be that indicator, why do you propose that this indicator should be included, और उस इंडिकेटर को कंप्यूट करने के लिए किस तरह का हमें डेटा कलेक्ट करना चाहिए, और उस डेटा को कलेक्ट करने के लिए सिस्टम के अंदर कैसे उसको इंटीग्रेट कर सकते हैं, एंड देन फाइनली उसको कंप्यूट करने के लिए कैसे उसकी मेथोडोलॉजी को डेवलप किया जाए. So these are some of the questions that we have posed, and we have requested the stakeholders to give us as much feedback as possible on these particular issues. हमने वेबसाइट पे एक लिंक भी प्रोवाइड किया हुआ है जहां पर ये आपका consultation paper available है, and we have provided a Google link which you can click and provide your feedback automatically. The last date for providing the feedback that we have currently set is 21st of July. ये हमने consultation paper 22nd of June को upload किया था, so we set a 1 month window for people to read and comprehensively provide us with the feedback. So I'll stop here, and we will welcome any comments or any kind of suggestions that you may have. So we'll now open it up, and both myself and Dr. Sudha will be available to respond to any questions that you have. You can leave your questions in the chat box, or अगर आप Q&A में भी करें, हम start कर सकते हैं by looking at some of the questions.
Just one thing, Dr. Shankar, I think one point they should also be aware of is that if there is a confirmed fraud, then there is no incentive, whether it's accreditation or any kind of value-based. So that would automatically disqualify the hospital from getting any incentive.
Yeah. And what it also means is that hospitals जिनका की accreditation नहीं है, वो भी remaining 50% of incentive के लिए eligible होंगे, provided they perform the outcomes are up to the level and they also have good scores. So maybe we can start responding to some of the questions that are available. So there is a question ki, have we already started giving 5% incentive for bronze certification? Yes, this is already configured, and the hospitals who have bronze certifications do get 5% additional incentive.
In addition, if the state also has agreed to give that incentive. So at the national level, this is approved, but many states might not have gone ahead and implemented that policy decision. You can check with your states exactly whether it is being automatically done.
So there is a second question, care of the patient after completion of chemotherapy and radiotherapy too for cancer patients. So it's a question not necessarily related to this particular thing, but just to respond, I think we have comprehensively revised the oncology packages as part of this health benefit package that has now been released. Plus, if there are complications or end of life care or hospitalized treatment that is required after chemotherapy or radiotherapy, that is for certain late stage complications, then there are new set of palliative care packages also that have been introduced, which are things that the patients require. Next comment is related to nutritional aspects of patient after completion. So we do not have that in the because the scheme is mainly designed for providing hospitalization care. So that's it. There's a question, Dr. Sudha, if you want to respond to this. What is the call center number for AB PMJAY?
So it is 14555, and recently we have also launched the hospital hotline. So that is 14413. So these are two numbers for hospitals. They can connect with 14413, and the beneficiaries or anybody else, if they have any general queries also, this 14555 is something that they can reach out to.
Right. How will data, there's one question on how will data be captured for criteria number 2, readmission rate for dialysis centers or cancer centers. So since these conditions are not considered. So as we mentioned that because, so we will not compute the readmission rate indicator for those packages which involve dialysis or where there is a chemo package which is to be delivered in a daycare setting. So but however, these dialysis centers or cancer centers would still be subject to the assessment for the remaining indicators 1 to 4, which does not, I mean 1 to 5 minus the second indicator, and the average of the remaining indicators would be taken. So what it means is it's just that this is not being taken, but that will not affect the overall rating otherwise. So their rating would be based on the remaining indicators, and so that will be the way. Certification based incentives is for public hospitals only or government too? So as we mentioned that the certification based incentive is for both public and private hospitals, and we mentioned that for public hospitals the incentive structure that corresponding to the NABH, the NQAS certified public hospitals are also eligible for a 15% incentive. This has already been introduced since this early part of this year itself, and so that's it. What will be the maximum incentive an institution can get? It's subject to the different entities that you might be eligible to. So, but these incentives are ultimately the ones that are related to type, as I mentioned, that the metro and the teaching hospital incentive might will be subsumed once the HPP 2022 comes into place. But otherwise, whatever incentives were already there, they are currently in place and they continue to be applied on a compound basis rather than simple arithmetic basis. So there can be a calculation. I think overall it adds up to, I think Dr. Sudha might add on, but I think overall it may add up to close to almost like 40%.
39%.
39
around 39%. It's cumulative right now, so they could 39%.
All the incentives apply to a particular hospital.
But the thing is, if there are certain exclusions, if they belong to a metro, then the other incentive does not, the 10% is not there. So it depends on, exactly what all criteria, whether they fulfill the hospital. It's a DNB teaching, whether it is in an aspirational district. So all the things, max cumulative is 39%. currently.
So I'm shifting to the chat now, Dr. Sudha, and I'll try and read out some questions if and if we
There
can.
is some more like QA ka some more questions are there. Then we can go to the chat again. Yes.
Okay.
Something on denial of patients. I think that is something that you should report it as a part of either the CGRMS or grievance reporting system. So you can complain any such incidents through the CGRMS. Can a public hospital get NQAS and non-certification incentive both? See, NQAS, once you get, you're at a higher level. That is, you're at a 15% incentive if you get full national level NQAS. So why do you want to go? There is no, logic in giving bronze certification 5% in addition. So you're getting already the highest. So we would recommend all the hospitals, the public hospitals, to go in for the NQAS national so that you can reach the gold level of, certifications. Bronze is just to initiate and motivate the hospitals to start in the quality pathway. So let's not limit only to that, and we would request you to move ahead up to NQAS. Incentives not applicable. I think states have full flexibility in actually implementing the incentives, though at the national policy level, we have given the guidelines. So that would be based on their own financial and the availability of such hospitals. So they would take the final call on exactly what should be the certification addition percentage that would be given as an incentive.
There's a question.
Yeah. Value-based care should also be able to fulfill the criteria of quality, but what if the hospital are not able to do so, as it is a major. See, we are looking at continuous improvement. So right now, maybe there is some issues. So we can identify what are the issues, why certain hospitals are not able to perform as well as other hospitals. So that gives us a feedback also, and it also helps the hospitals to look back their own efficiencies and the performance and identify specific areas why they are not able to fulfill the criteria. So maybe as we go ahead in the pilots, we might identify some more, insights. We could work on those things and specifically look at it. Not received revised packages, we're still following the old channels. So HPP 2022, I don't know from which state. I'm not sure whether your state has given the concurrence, and its integration is in process. So we hope to get that done in a week's time. So from our end, we are ready. So as and when the state concurrences are given, then I think plus or minus 1 week, we are closing the integration. So
I can just inform that we have about 7 states that have already concurred, which include UP, Madhya Pradesh, Uttar Pradesh, Madhya Pradesh, Sikkim, Ladakh, Manipur, any other, Nagaland as well, I think so. No.
Nagaland has concurred, but they will do it with October with the launch of the UHC scheme.
Yeah. So these are some states, and for the national health NHCPs also, they have also concurred. So the process of integration of the new package for these states is currently underway, and soon this will be available. So 15% incentive to the teaching hospitals for running the PGDNB in view of the building infrastructure. So basically, we are not. So currently, this 15% incentive is operating, but we are saying that when we introduce the HPP 2022, we have an incentive that is auto built into the procedure price that is for a tertiary care procedure. So basically, what we also don't want to encourage is that a lot of teaching hospitals continue to provide secondary care. So if you are actually providing a tertiary care in the teaching hospital, then there is automatically an incentive that has been built into the price itself. So that's the.
So currently it's 10%. So what they are asking is to increase it to 15%. I think we will still go with 10% because 15% we have only given for the fully accredited NABH. So for DNB teaching, the current 10% will be merged with the tertiary and the secondary incentive, the differential pricing that is there already. I think if it's applicable, then almost all the hospital will get the certification. That is good. If all the hospitals will get the certification benchmark, then we are very happy. I think if Gujarat SHA is there on the call, they can also respond. Maybe it's a good initiative if they would like to take this because many hospitals, I'm sure in Gujarat, have already got a lot of certifications.
This was Lama Dama was again a question that was discussed quite a lot in our discussions. The issue why the Lama Dama was not included was because Lama Dama is also dependent on the individual patient decision in certain cases, and so we did not necessarily wanted to penalize the hospital just in case the decision to leave against medical advice was based on the individual decision. So that's the reason. So it is not mandatory to have certification. We encourage you to have certifications, but it's not mandatory.
But you will lose out on the incentive if it is not certified. So there is a financial
incentive to
fallout if you don't go for certification. But
right. What if the PMAM scores the patient poorly during admission if it is the patient condition was not as bad? So we do recognize that there are these challenges in any kind of a structure that we develop and any kind of data or information that we collect. And as a result, only the ones that were much more vulnerable to any kind of gaming, we have tried to refrain from those indicators. We do not completely disagree with your point that there is a possibility that PMAM may engage in scoring a particular patient much more worse than what he is, and we'll have to. But what we will also try to do as part of an audit system is that we have also introduced an EQ5D system of disease classification and coding, and we're also trying to collect information on multiple diagnosis, multiple primary diagnosis as well. So at some stage, we'll also try to have some kind of system whereby there can be correlation between the kind of coding of the disease condition that is being done as well as the kind of quality of life that is being reported. And we'll try on a sample basis to institute such mechanisms to ensure that the quality of data that is being collected for computing these indicators does not falter too significantly.
And also trend analysis will also give us some information on, if the hospital is also regularly reporting such kind of aberrations compared to similar conditions in other hospitals. So we will be able to pick up those as some deviant hospitals, and we can look at whether it needs more training to the PMAM or is it just a very, intentional kind of manipulation. So we will take such things seriously, and let's see how we can do more of such things. Maybe in the pilot, we will also get some more information on these things.
I just wanted to sort of remind my colleagues who are also attending this workshop to please keep copying all these questions so that we collate all these questions and we respond to them in a detailed manner subsequently also when we draft the responses.
Yeah. Any subdivision of incentives like operating doctors, team supporting, I think that is a separate set of incentives, at least for the public hospitals. We have the fund utilization incentives. So based on the claims that is generated by the hospital, that incentive is divided among the treating team. So I think that's a completely different thing. This would actually is a per claim reimbursement. What will be the final reimbursement for that patient is what we are talking here. Whereas the other one would be your hospital level total reimbursement that you have received. How do you divide that into incentives? So these are two different things. And I think there is already a guideline available, especially for the public hospitals, how to utilize them. And for private, it is left to their own internal facility decision of whom, if they want to share that incentives.
So currently the policy does not cover the over-the-counter medicines or the transport costs, etc. So
yeah, I think infection control is something that is so critical for any facility, whether it's public or private. So it's important that every hospital keeps an eye on that rate and keeps monitoring it, so that it will definitely improve the patient care, because we don't want a patient to go back with an additional problem. So we want to make sure that his issues as much as possible are treated and he goes back healthy, right?
I just wanted to add to this actually that while it is extremely important, and as Dr. Sudha has also mentioned, it is also important to recognize that just as there was a previous comment that the PMAM can perhaps sort of make some his own interpretation and report a particular patient as a worse of quality in order to show that the improvement in quality of life is much more. On a similar note, we do recognize that there are going to be challenges in trying to make sure that the reporting of hospital infection, hospital-acquired infections, or the parameters for hospital infection control are appropriately reported. So because of this issue, it has not been linked to the incentive structure that is being proposed. However, it is not to say that it is something that is not within the ambit of our thinking to ensure that there is a appropriate emphasis on that. And in all our efforts towards trying to work with the empaneled hospitals, where the quality cells are trying to support them, and the quality audit checklists that we have prepared, in all of these, we keep the monitoring of the infection control practices as something that is very integral and functional to the overall quality improvement activities.
How to increase hospital incentive 15% up to? I think that is left to the hospital. If you expand your scope of services and go through higher level of certification and have better quality of care, then definitely you can increase the percentage incentive. But at the national level, whatever we have now frozen in terms of the percentage that will be provided, I think that would stay for some time until we rework it in future.
There's one question from PGI Chandigarh, which is on, please clarify on how will the value-based system be merged with the HPP rates. So that's an interesting question, where we are still debating on whether to have it as a prospective or a retrospective system. So the way that we are, however, conceived it so far is that when there is a monitoring based on these indicators over a quarter, based on that, a ranking or a scoring of the hospital would be generated, and based on that, the entitlement of the hospital to a particular level of value-based incentive would be determined. And then the subsequent next quarters, all the care that is being delivered by the hospital, a option is that we prospectively add on that incentive to each of the HPPs that are being booked. Or there is the second possibility is that for the previous set of quarter for which they have been observed or monitored, we give a retrospective payment to the hospital for this set of packages that they had performed or they had utilized. But I think the consultation paper does not clearly spell out this particular aspect. It's a good suggestion that you have given. We'll definitely try to articulate this in the revised version for our paper.
I think incentivizing healthcare workers will in turn reduce their attention towards non-AB PMJAY beneficiaries. I'm not sure. I think as we go ahead, right now we are already covering 40% of the population, at least in most of the states, and a little bit more in some states who have expanded to UHCs. I don't think so that we are not at a fallout of such things, because incentivizing healthcare workers, we hope that definitely it would build a system of quality. It's a culture of quality that will be built, and maybe the non-AB PMJAY beneficiaries may actually benefit with this kind of the additional soft skill and how they're handling the patients and the kind of satisfaction that they want to. I think that skill set may improve, and we hope the benefit may spill over to the non-PMJY too.
Just to add to this, I think there's also an important connotation that generally it is seen that the non-PMJY patients are likely to have more voice as well, and they are likely to sort of register their grievance or register their dissatisfaction to the care that is being provided and automatically get the necessary care. Whereas we want to sort of more empower our beneficiary more, differentially more than perhaps even the. So I think in a way it kind of, as Dr. Sudha has also mentioned, it creates a culture of improving the quality of care and also empowers the beneficiaries that has a relatively lesser voice in the entire system.
I think we can now go to the chat box, whichever is not repeated. Then because we are done with this one.
Yeah.
Qualification regarding OMFS package. Should we go from the first?
Let's go from
the top.
First is related to NQAS certified PHC will get percentage in our state. PMJAY has also been extended to PMJAY. I think that's a standard point. So I think we've answered this as part of the other question as well.
Any NQAS, if you have got, even a PHC has got a national level certification, you will get the incentive. So you can. I have a small question. If a rural hospital is not eligible for quality health that they are providing in terms of infrastructure technology, so what do you suggest for them? Are there major problems? I think as you have seen accreditation, you might not be getting it but the value-based performance is based on the patient feedback and patient-related factors. I think you will still be eligible for the 50% of the other incentive, which are more performance-based. This also we had, in the general context, responded to.
And that's another sort of, what should I say, novelty of the new system is that it not only incentivizes the hospitals that have an accreditation, but also the hospitals that sometimes feel difficult to get the accreditation, but at least in terms of the services that they are performing well in terms of patient satisfaction, etc., and outcomes of the patients are good. I think it in a way kind of incentivizes relatively those smaller hospitals as well.
When are we going to get the outcomes of quality matrix, which is being implemented in states? So I don't know which states. Maybe you should reach out to your quality cell team in your state, and they might be able to give you some feedback. So let's go alternate, Dr. Shankar, so that we continuously are ready with the next answer as the time is running out.
Yeah. So I think again a lot of questions are related to queries that the individual hospitals might need to get clarified from the SHAs. So like I'm working in a government setup. Does the list have been updated regarding procedures which are not included? So yeah, the lists are updated, and the states once they give the concurrence to move to the new benefit package, then the system is configured according to the revised package. So depending on which state you are and which package is currently eligible to, you will be able to see the set of procedures that are available.
So as we explained, yes, it is the bifurcation of the accreditation amount, so that quality does not mean just accreditation. So I think that has been clearly explained in the presentation also, that we are moving beyond accreditation. So that is important to understand, that this would be value addition beyond just getting a certificate and just forgetting about it. So it's important that continuity of quality of care is being given to the patient.
Patient satisfaction, we know it's part of the NQAS through the Mera Aspatal program as well, but we're trying to also have more indicators, plus the level of coverage of the of such reporting system is could potentially be improved once we have this new system that is in place. So yeah.
So regarding again insights on readmission both in medical and surgical cases. So we have clear, I think there's a standard definition of readmission, whether it is for the same procedure or whether it is for a different condition and within a particular time, that is at least within 30-day repeat admissions for the same condition. So we will be looking at the kind of the condition that we are assessing, and based on the hospitals that are booking such cases, we will know based on the patient ID whether it has been admitted to the same hospital, or even if it is admitted to a different hospital, we'll have the TMS data to verify, and we will review that before taking a call on how many readmissions for that particular hospital. Shankar, you want to add on anything?
No, I think that's fine. So for there's a query from the hospital in Karnal to say that which website should we be following for NQAS certification. I think it's the you should inquire from the NHM website or the Office of the National Health Mission as well, and they should be able to clarify this question. Your civil surgeon office may also be able to provide you with information.
I think the agreement on the provider, it is mostly a policy decision, both at the national level and at the state level. So, it is beyond what the package rate that is fixed. So this incentive structure, in most of the MOUs, it's already clear that, it is based on the incentive changes, any changes in incentive structures during the MOU period with the hospital. So that will be applicable, and the state and national will definitely have a say in what that percentage would be. So I'm not sure whether the consent from the hospital is a part of this process. It's more a national and a state level policies that would be working at.
There's a question on whether or not there would be a validation of the calculations at the back end. So yes, the first 3 months of the pilot that we were saying is basically to sort of test the system, do a lot of rigorous analysis to compute these indicators, ensure that these are auto calculated, and also make some kind of assessments at the baseline also, that what is the general reporting pattern, etc., and how do different hospitals report differently for each of these indicators. So a lot of that will happen during the pilot, and then subsequently this would help us to develop some validation checks, some range and consistency checks also for the kind of input values that are being reported, and also the usual pattern we would be able to identify that will help us in setting up this kind of validation system.
I think for out-of-pocket expenditure, any such grievances, there is a defined method of reviewing such grievances in terms of for what and whether it is related to the treatment that the patient is admitted, and whether it is non-medical costs. So there is a defined process, and the grievance, unless it is confirmed that it is beyond the scheme guidelines, that the amount is collected, then only it will be considered for any kind of scoring.
The next question we have already mentioned, NQAS ultimately is related to its state-specific decision if you're not seeing that in the TMS. But I think that gradually most of the states are coming on board, because this is something that is there. But then ultimately it becomes a state-specific decision.
So I think the case-based payment would definitely be at the time of discharge. So this, what we are looking at is the incentive part is one which would be later transferred to a hospital. So we are not currently, what is happening is along with the claim, the incentive for accreditation is also being transferred to the hospital account. So right now what we are looking at is the patient, the treatment amount will definitely reach the hospital after the claim is processed and approved, but just the incentive amount is what we are trying to see if at the quarterly aspect the hospital will receive based on all these factors.
So
patient will not get any payment, it's the hospital who will get the payment. Yes, Dr. Shah.
No. I was just about to respond to the next one. So it says that there's no bifurcation between queries and grievances. Actually, there is a drop down to actually mention that whatever you are reporting, whether it is a query of general nature or whether it is a grievance, it does have certain categories in which you can classify your whatever you want to register in the CGRMS.
And in the CGRMS, a new feature is also included as denial of services. So I think there is enough categories, and these quality audits of grievances are also happening. I think states are very much aware that, whatever grievance is registered, the quality closure of these such grievances are reviewed both at SHA end and at NHA end. So there is a very systematic process of registering finally or giving a decision whether this was a grievance or not.
Sorry, Dr. Sudha, you can please carry on. I just got distracted.
Okay. So the other one is the entire value-based system is based on the call center personnel and TMA. So their own behavior have been a grievance for a patient. Aren't we relying upon this cadre too much together? Plus the traffic on the grievance is too low to assess the actual scale. Yes, definitely. This is something, it is just one or I think the 2 parameters out of the 5 parameters. So PMAM's feedback and the grievances. So there is a check on these things. So if there is any kind of aberrant behavior among these cadre of staff, also we will be able to track it through the kind of trends that we see from a particular PMAM or from a particular hospital. And CGRMS, yes, the traffic is too low, but that is one of the most, I think, genuine grievances. Also, people take that extra effort to go through the portal and ensure they track their grievances. So there is a more, pay. And even if the CGRMS, we are not receiving a grievance, I think the state, even if they receive a letter, if they receive an email, if they receive any kind of message at the district level, all these are being re-entered in the CGRMS portal. So the patient themselves may not have been entered, but all the sources, then again the state or the national grievance team re-enter it so that it gets tracked and addressed. So we are not just looking at direct entry of CGRMS, but multiple sources into the CGRMS that goes in.
I'll just add on to this particular thing only that we are also, as we mentioned, proposing that we'll try to create an app that would be available for the patient to self-report some of these aspects. So which means that it is not just dependent only on PMAM or the call center. In cases where the patient is literate and has an access to a smartphone and is able to fill out, we will use the patient reported as the first preferred option for the information that we collect.
And I think, since I'm looking at grievance also right now for some time, I've seen that the system, there is a lot of, strong points that we can definitely, that will help our value-based care assessment. So I find that, these issues would be much lesser at the scale that we are looking at.
And we do recognize that for those hospitals that are certified, there would be now an additional monitoring. But I think that monitoring, whatever we are proposing, is for the betterment of the beneficiary itself. So eventually we want the outcomes to be better, and we're just adding another layer beyond the certification, because what we've seen is that if the certification period goes for 3 years, then once the hospital is certified, the next 3 years, irrespective of the nature of the care that actually gets delivered, the incentive continues to be dispersed. So it is more of bringing in that culture of the culture of quality and value within the entire service provisioning that we are trying to incorporate this. It shouldn't be construed as just saying that we are disincentivizing the hospitals that have a quality accreditation as of now.
The next question, providers, we have already answered. So I think HPP concurrence, first phase for public and second phase for private. I think the state can take a call on that. So state has the complete flexibility of how they want to give the concurrence. But we would hope that if you can do it in a much more, consistent way for both the type of hospital, it is good. But in case you want to do it in a phase-based, considering it for the public hospital, you can send that proposal to us, and then we can take our review and approval internally, and we can send a reply back whether that is feasible or not.
There is one suggestion on the oral and maxillofacial surgery, increasing the number of packages. So we have now decided that the package revision would be an annual activity. So now that the package has been revised, next year, April 2023, the new package would be announced. we have set up a new portal on the website to receive nominations for new inclusions into the health benefit package. So my suggestion would be that if you can submit any inclusion request for the health benefit package on that portal, and there is a series of information that is requested from the person who submits a given topic, which would be then evaluated using standard criteria and standard methods of analysis to make a decision on whether or not it should be incorporated.
I think Ayush doctors to get incentives by treating a patient in our STGs, it is clear exactly who can treat and what is the minimum qualification of the treating doctor. And the support team, again, I think certain as direct treatment is not permitted, but if they are supporting a patient treatment by a treating doctor, so we are not dealing with any incentives directly to any treating team. So I think that is the hospital, and in public hospital there is a laid out guidelines, and in terms of they treating the patient, there is absolutely the clear guidelines is available as per STGs for what packages, what is the minimum qualification of the treating doctor. So I don't remember anywhere Ayush doctors being listed, because it is not part of the kind of care that we provide, secondary and tertiary care. So they might not be part of the main treating doctor at any of our procedures.
The frequency of assessment as proposed right now, so while the data would continue to be collected on a regular basis as the patients are being treated, however, the computations would finally be made available at a quarterly basis to make decisions on the incentives.
I think next one regarding the Puducherry, some clarification, I think I will request HPP team to review and give a feedback on that, because we don't know exactly what query has been requested. So we will ask somebody from our team to respond to your query on that.
So there is a question from I think the CEO Chhattisgarh office. The option of 15% to NQA certified is not yet functional in the HEM. So we'll definitely get it checked from the IT, sir, and we'll get back to you on an individual basis.
It has a release date of next week, so I'm not. It is it's all configured. It has to be released in the TMS. I hope so by next week it should be released by TCS. Priyanka, you can update on that. Get a check on that. Dr. Basim, length of stay as indicative suggestive is most of the private discharge the patient, particularly lab receptive, but length of stay can be used as an indicator for accessing the quality of length of stay that we have mentioned in our STG is indicative, and that is based on the kind of overall experience of various experts on the minimum length of stay. It could be plus or minus one day, 2 day, but it depends. We are currently not going to use it as one of the indicator for quality of care. Whatever we have used, the 5 indicators, we can say that they are tracer indicators. We can actually have a lot of indicators if we want to do very in-depth study or in-depth review of these kind of things. So what currently we have listed is just the tracer indicators based on which we will start on that, and slowly we can expand as we perfect the system and the way this can be operationalized. We might add or include more variables into the mix.
There's a question on the nature of the way that beneficiary satisfaction is elicited, and it may encompass not just the care that is actually provided, but also the other aspects like behavior of the staff, etc., and hygiene. So what I'll just like to say is that the connotation of the patient satisfaction is a very complex one, and it ideally takes into account all of these features. So we do recognize that whatever the patient will report is going to be based on his overall experience in the hospital, which is the type of care provided and his how much he got better, but also with the other aspects of the care, which includes the way he has been spoken to, the kind of hygiene which has been maintained, etc., the kind of food that has been given, etc. So we do intend to actually capture all of that, which becomes part of the overall framework of responsive patient care. I
think retrospective assessment, financial implications, I'm not sure that is possible. I think with the integration, all thing would be for prospective, because it's difficult to go back and recalculate give it. So we will check with our finance once, but I think as a first response, I find that it will be mostly prospective in nature for NQuas and bronze certification once it is activated in the TMS.
Yeah, as clarified earlier, the hospitals will continue to receive the claim amount as soon as they have treated and discharged a given patient and the claim has been approved, which goes as per the previous practice. This particular change in the way that the money is being distributed for incentives is only going to influence the incentive component of the overall payment. It will not influence the base rate that the hospital is entitled to receive.
I think rest of the things are repetitive. So for package inclusions, I think you can, Priyanka or somebody can post the link so that they can, in our PMJAY website, I think there is what's new, there is scrolling also. So you can identify the new inclusions for packages and get it through the website.
We are working with the IT to get the incorporation of the HPP 2022. We know, I mean, it's a delay and we're trying as much as possible to expedite that. The last, I think they've given us a timeline of probably
this week.
So.
Okay, so is there a limitation in raising a second claim? If there is a need within 3 months of a previous admission. So I think raising a second claim in sense if the patient is admitted for a different indication or if it's a readmission, I think there is no restriction as such unless it is a once in a lifetime package where you cannot raise, the IT will not let you raise the package. So I think you can raise the package, and there are certain conditions where we know that these claims cannot be raised again. So in such cases, definitely the IT is already configured to limit such kind of wrong submission of additional claims for such packages.
So there's again the repeat of the question, but they've sought the clarification from Chhattisgarh. I think if the primary health center is a empaneled public health facility, empaneled healthcare facility, and you are booking packages, then irrespective of who's the provider, in charge, the facility as such is entitled to the kind of rates that are being set and the incentives that are being delivered. So that's just a clarification. It was just to say that in specific standalone centers, there are certain eligibility rules that have been drafted in the standard treatment guidelines in terms of who are entitled to perform certain procedures. And it was in that light, I think, that the response was given that who is eligible to perform a given procedures. I think we've finished the chat part, and we don't have any specific in the Q&A also, and we've reached to the end of the session as well. So I think it's been a very useful session. We've got a lot of good feedback and comments as well, and we've taken a note, and I'm hoping that the team has also copied all the comments and in both the Q&A and the chat box. And we will try and include all of these also as part of our responses that we will subsequently collate and post on our website for the consultation paper. For those of you who might have read a previous consultation paper on pricing that we had earlier posted, we have already drafted the responses and we have posted them today on our website. So if those of you who had commented on the previous consultation paper on provider payment and pricing, we will you can go and look at the responses that we have submitted there, and a culmination of all that has translated into improvement of that consultation paper into now a policy document on pricing would be released very soon, shortly by the NHA, and we'll circulate that once it is finalized and drafted in the form of a policy document. So any final remarks from your side, Dr. Sudha?
No, I think we have had a good feedback, and definitely we will be reaching out to you for the pilots mainly because we want to test the system before we go large scale. And, this has financial implications. So we want to make sure that the systems are right and we are able to, get whatever we planned operationalized. So in that sense, I would suggest that the quality cells and the states who are here can send us your concurrence or, your interest to pilot this without any financial implication of the changes. So we will try and just do a process pilot to start with, to understand how we capture the data and how we, use it to calculate the kind of incentive before or after this kind of pilot is rolled out. So in that sense, we would request definitely that our team will be following up with your quality cells to get the concurrence to at least 5 to 6 pilot states who would be interested.
I think we have some hands raised. Maybe we can ask at least one or two to maybe respond. I think Dr. Amit Yadav is there on the call, and he has raised his hand. If the NEGT team could unmute Dr. Amit Yadav and we can have his feedback.
You can unmute and speak.
Sir, you can unmute yourself and speak. I think you would be able to unmute yourself now.
And also, any other SHA leadership wants to share some concerns, please raise your hand and we could unmute you.
Anand Lakshmi, if you want to.
So
I am given the permission, but nobody is the talk.
Sorry?
Yes, Ravi Patel is the online, sir. Hello?
Hello,
Yes.
sir. Hello, sir.
Yes, madam.
Sir, regarding incentives for NABH accreditation, when in the drop down, no, sir, when we say NABH full accreditation, again, when you go to the action, there are some few drop downs. In that first, it is mentioned as teaching hospital. Then subsequently, it is written PG and DNB courses. So when we click the NABH accreditation full and teaching hospital, it is showing us 125%. Whereas when we click NABH full accreditation and PG and DNB course, it is showing us 110%. So I have not yet got clarification in this. I've sent a letter regarding this to NHA, sir. So if possible, if we had some clarification now, it is okay. Otherwise, I'll wait for the reply from NHA, sir.
Sure, we'll respond to that.
Like in the drop down itself, there are multiple things like in aspirational district, NABH in hospital in our, but it's a private medical college which has got a full NABH certification. And again, on the action, there are multiple things. That multiple things is showing, I mean, if it is a PG and DNB course itself, it's a teaching hospital only. I do not know why again a special thing for teaching hospital it has come.
Check that.
Can I answer this?
Yes, Priyanka.
Ma'am, this seems to be an IT issue. So I would rather suggest that there is some problem in the drop-down menu. I would also request you to please raise a ticket because during our UAT, we have not seen this kind of problem. So this is more related to an IT issue. So I request you to raise a ticket. We definitely, our team will look into it.
Okay. Okay, ma'am. But then we have sent a screenshot of everything to NHA. I will raise a ticket in this as said.
Thank you, ma'am.
Thank you. Thank you.
So anyone else who has raised their hands? Yeah.
Dr. Patel, you had something to say?
Okay, I think we can.
Yeah, we can close it. So thank you very much for all the feedback and all the comments and suggestions. We're still not finalized. The time to submit your feedback and other suggestions is still open. We are accepting any suggestions, etc. till 21st of July. So we've already shared the link with you. If you can please send us your suggestions through that Google link, or else there's a Excel spreadsheet also that is posted there and available. You can simply download that spreadsheet write your comments in the respective columns and send it as to an email that has also been specified, that is available. Thank you very much.
Thank you.